So today's program was really about giving you as much insight as possible into how decisions are made on some of the really cutting edge issues in myeloma today. And we actually started this with Dr. Callender last year, and it went so well. I think it's going to become a permanent part of our program. One of the things that I have always enjoyed in the years that I've been involved in myeloma, when I go to the American Society of Hematology meeting, I get to go to cocktail receptions and things like that, and I get to meet people. And what I have found over the years is it's usually when I eavesdrop on those conversations, that's when I learn everything. That's when I really learned the truth about what's going on. So I did I do an unfair thing to the doctors now. I basically say, I want you to have a 15 to 20 minute conversation amongst yourselves about what you're thinking about in myeloma these days in front of the audience. And so we're going to witness that for the next 15, 20 minutes. And then from that, we'll go right to the Q&A. So if you have questions, please think of them now. So, and with that, discuss. Who would like to start?
Well, since Natalie's had experience.
Okay. Well, so one of the things that we didn't touch upon today that is actually a very, very important issue in myeloma is what do we do about everybody's bones? And this is an area where I think, unfortunately, some progress really needs to be made. So I guess I would just ask you all, what are you doing when a person is first diagnosed with myeloma in terms of medication or recommendations for bone health?
So this is such a dear topic to my heart because it's also what our lab research works on.
So of course, many of you know that in a lifetime of patients with multiple myeloma, a majority of patients will end up with bone complications, and that's anything and everything from bone pain, fracture. What is unique, though, is these bone lesions, they don't go away. The cancer may be in remission. The scans, though, will still continue to show bones that don't heal. And that's kind of different comparing to if you were to fall and break a bone, that bone will heal up over time. Even when we compare myeloma bone problem to other cancers that's metastasized to bones, prostate, breast cancer, they go to bones sometimes too. But the reaction to the bone is very different. As it turned out, myeloma bone problem is a combination of accelerating bone loss, but also lack of bone repair. And that lack of repair continues to persist even after the cancer goes into remission. So knowing the state of the bone to start out with is so important. So patients definitely should have a whole skeletal imaging. And these days we go above and beyond X-rays. We look at more sensitive tests, whole body CAT scan, PET CT, whole body MRI. This gives us a sense for the areas that are at risk. And this becomes something that we can follow over time. Now we have treatments that many of you are on. They are something called zoledronic acid or Zometa, or an injection of something called denosumab or Xgeva. Now, what they do is they block the bone loss. They block cells in the bone called osteoclasts, which remove extra bones. So if you don't remove the extra bones and your bones get thicker, it turns out the cancer cells wake up these osteoclast cells. If you shut them down, then they cannot eat up the bones. But what we don't have yet is the treatment that wakes up the new bone formation. And that I think is where research is still lacking. So from me, serial follow-up, these agents that are available to us, and definitely calcium and vitamin D supplements. You want to be sure that you're taking the best benefit of these otherwise natural stuff, but also exercise. It really does help building new bones.
I think we do the same. I would say that we start out usually with Zometa, and we usually give it monthly for the first year, and then every 3 months out to year 2. And if then the patient disease is not very active, we give a break and resume when the disease becomes active again. I think the Xgeva has some advantages. It's, I think, a little more effective. It is also got some issues that Zometa has in terms of more convenient administration. It's an injection into the skin rather than an IV. And also patients with myeloma may have kidney problems, which sometimes make Zometa administration a little more difficult, and Xgeva can be given in that situation. So, but having said that, we still tend to use Zometa. It's something that we haven't moved fully to Xgeva yet. What about you?
Yeah, no, I think this is really an area that we are sort of way behind in because, as Dr. Suvasaka mentioned, osteoclasts that normally are there to build up bone, and then you have, to take down bone, and you have osteoblasts that build up bone. In myeloma, the osteoclasts are clearly overacted, but the osteoblasts are kind of MIA. They're not making new bone, and that's actually very different than other types of cancer that go to bone, because you can show if people commonly with advanced breast cancer or prostate cancer get metastases, get tumor deposits in the bone, and they actually get sclerotic bone, meaning they get extra bone. And so that's a more typical thing you see when cancer travels to bone. But in myeloma, for some reason, the osteoblasts are really tamped down and they are not making new bone. And so far, we don't know how to unlock that yet. And we don't know, there are some agents, particularly there's one has a trade name called Forteo, which is used in osteoporosis. There's been a lot of concern about using that drug in myeloma because of some older animal data that showed that you were actually stimulating myeloma growth by giving that drug. So I think we're a little bit stuck right now. And I would also be interested in asking here, how often are you sending your patients for kyphoplasty or vertebroplasty as interventions that can help with pain or things like that?
We use it very liberally, especially vertebroplasty. I think that it is a procedure that...
know what that is? Maybe you wanted to...
Yeah, so that is a procedure where you, I think layman term would inject cement into the vertebra using a needle and expand the vertebra back to its...
Although it's really not cement.
It's not cement, yeah, it's not cement, but in layman's term, and then take the pressure of the nerve roots, which often helps with fairly prompt relief of pain. And we do that fairly liberally in patients who have fractures, and it usually works when the fractures are relatively recent, and it is something that we send our patients to either the pain service or the interventional radiologist to do.
Right. So I couldn't agree more. I mean, I think we try to use all available technologies to really help boosting the good long-term outcome, right? So we're talking about stopping the osteoclast to try to increase bone thickness over time. But what if there's already such a significant bone loss in particular level, or there's already a collapse of the spine? So why the spine? It's probably because while myeloma is a systemic problem that affects, in theory, it could affect any bones in the body. The bones that are really mostly of concern would be the areas that bear weight, right? So the spine is at risk because really it's the gravity and the weight, and there's a lot of twisting motion to the spine as well. So when myeloma melt away the bones, it just makes the bone as thin as eggshell. So you could actually have a collapse really just because of the gravity. So the technology that's referred to is really helping boosting up the level at any particular ones that has a lot of fracture, that has a lot of height loss, so that you don't end up with patients who are having this like terribly bent back. But it is also a tricky business in that you need people with good hands and experience in dealing with this, because I was saying that there could be multiple levels that are affected. The tricky business is you want to fix what you can fix, but you don't want to overdo it. Because if one injects a lot of this extra hard material into a bone that's already collapsed, it shoots pressure up and down the spine, right? If I'm trying to actually inject something that increases the height, sometimes what happens is if it's overdone, it actually causes fracture at the level above and below. It's also sort of important that you work with the pain clinic that works well with the cancer doctor. This is different comparing to osteoporosis. But to Dr. Calendar's point, I don't want to sound hopeless at all about the bone. It is an area of ongoing research, and our lab is funded by the VA, and we work on sort of building new bones that hopefully isn't just helping people live better, but there's some data to show that these osteoblast cells, the new bone formation cells, if you keep them active, they may even help preventing the cancer from growing back. That's yet to be seen, but that's why that's sort of in the work. There is a particular new medicine in osteoporosis that has been out for a few years now, called romosozumab, or its trade name is Evenity, and you probably see them on TV commercials. Now that's approved for osteoporosis, but hasn't really been explored in myeloma. There's some lab data, animal data, to show that it works by waking up this new bone formation that I was referring to. And in the animal model, it may actually slow down the growth of myeloma. So a lot that we want to do to tackle this very important problem.
One thing that I think we all appreciate now that we didn't maybe some years ago is that there's it appears that people who don't ostensibly have any bone problems should be getting something bone directed as well. So that I think is something that our British colleagues actually showed us a few years ago. And there also seems to be an actual survival advantage for Zometa for sure, and there's been a progression-free survival advantage for denosumab. So we really think these are important drugs to get. I guess I will try to be a little bit more provocative. How long do you continue them when somebody is first diagnosed?
As I said, we give it for 2 years and then stop if the disease is inactive at that point.
Okay.
This is something that I wish I had a better answer. So truth is this, when these drugs were approved, it was approved when the overall survival of myeloma patients weren't very long, unfortunately. And because our treatments were not very active, there was still ongoing bone loss. So the gist is that when it was approved, it was just to be given monthly for eternity. There was no number of cycles required. But then we learned that, well, there's a long-term complication. Many of you who are on this medicine get hounded by people like me to say, did you see your dentist? Did you see your dentist? It's mostly because when you stop the osteoclast, you cause an imbalance, right? Because now you're no longer having ability to remove bones that aren't formed well. So it turned out that there is a particular complication called osteonecrosis of the jaw. So what this is if you have trauma to the jawbone, particularly the lower one, such as if someone go in and do a tooth extraction and implant, it may not heal well. So you don't want to let your teeth go without care, because if you end up with invasive procedure, it's going to be a problem. It turns out that the increased bone thickness isn't without price to pay. You could have thick bones that's brittle, and that may not heal well, right? Something that's very hard could break. You want something that's a good balance. And this is why there's now a tendency to use less when you get patients into remission. Maybe there's not as excessive bone loss. You've gotten rid of the cancer. So maybe using less of this kind of drug may help us preventing or avoiding this long-term side effect. But see your dentist, absolutely. And if your dentist were going to do something invasive, be sure you tell them that you're on Zometa or Xgeva and have them reach out to the cancer doctor. It is so important to work together.
Yeah. So I guess another topic, maybe what do you do for infection prevention?
Well, I think, we all know that talking about antibodies and people should normally have antibodies in their blood. And many times when you have myeloma, the only antibody you have is the abnormal one. So we've known for a long time that actually people with myeloma are more susceptible to all sorts of infections, viral infections. Certainly something, pneumococcus, which is a streptococcus, is particularly common in people with myeloma. So I think what we like to do when somebody is newly diagnosed is we do actually use a fair amount of prophylaxis. So There is some concern that if patients are on very high doses of your favorite drug, dexamethasone, that this risk goes way up. And so the older method of dosing dexamethasone, when there were many days in a row, that clearly increased the risk of infection, in particular a type of pneumonia called pneumocystis pneumonia. So we do usually give our newly diagnosed patients weekend Bactrim as well as acyclovir, because both carfilzomib and bortezomib virtually have caused every patient to reactivate chickenpox. So shingles is a big problem if you're on those drugs. Now, one thing that nobody knows the answer to right now, since we have better shingles vaccines, if you had, because this comes up, people ask me if I had both of my Shingrix, can I not take the acyclovir if I'm on these drugs? I think we don't know, and I don't think anybody here is brave enough to tell somebody not to take an antiviral drug, because shingles is miserable if you get it.
No, I agree. I think that we do give acyclovir prophylaxis. I've had, just recently, a couple of patients who actually were being treated elsewhere. They had taken the Shingrix shot, but were not on acyclovir, and they did end up with zoster. So that is not 100%, I think, protection. As regards Bactrim, we are at the moment not using Bactrim or any antibacterial prophylaxis, which brings up the question about Levaquin or other bacterial prophylaxis, which the British have shown to be effective. Does anybody use Levaquin?
Yeah, so there's something called the TEAM trial where they used Levaquin versus nothing for a year and showed that they had, initially it looked like they actually had a survival advantage, although after year 2 that went away. But it depends on the patient. We've sometimes used it. Levaquin is a very all-purpose antibiotic, but it doesn't cover Streptococcus, it doesn't cover pneumococcus, and so that kind of leaves you unprotected for that. So when a couple of years ago, when the initial trial results were released, we actually were running around putting everybody on Levaquin, but we've kind of backed off.
I know. I don't use antibacterial agents so much, mostly also because it's probably already, honestly, a bit overused. Our patients are at higher risk of infection, and oftentimes it's not necessarily bacterial infection that bring them to us. Sometimes it's even viral infection, and people are already getting prescribed with antibacterial agents left and right. So I try to go with the bare minimum, I'd say. But I am with Dr. Rich and Dr. Callender entirely about the herpes prophylaxis, about using that acyclovir. We have found that even patients who are on acyclovir, particularly when they're still getting their combination drugs, when they're not necessarily in maintenance phase where we're not hitting their immune system as hard, when they're still early on in their treatment course, they're on a lot of steroid, a lot of combinations in the regimen, suppress immune system. That is a time that sometimes the breakthrough will happen, even people who are taking the acyclovir prophylaxis. So it's probably not the time to take the prevention lightly. It's probably easier to prevent and scale back later.
And what about, I guess we talked about IVIG immunoglobulin in the era of CAR-T and bispecifics, but what about in earlier journey of the patient? Do you use it to prevent infections?
Interestingly, I actually... So what's being referred to is this. Good number of our patients, despite the fact that they're having plasma cells, myeloma cells that are dumping out all kinds of antibody-like protein, they're actually not making enough of normal antibodies to be preventive. And in fact, recurrent infections, one of the symptoms patients then come to us to eventually learn that it's probably myeloma that undermine their health. So as we're treating the cancer, should we also be infusing the normal antibody to help lifting up the level of the normal antibody? Classically, it is approved for patients who've already had recurrent infection. So I haven't used it in everyone, but the new move for why we're talking about this CAR-T and bispecific is these patients have not only very low level of antibody, it continues to be low for a long time, because when these BCMA is being targeted, BCMA is actually overexpressed, meaning that it is showing up more on the surface of myeloma cells, a good target there. But it also is uniquely expressed on normal plasma cells. So when we use this very effective technology that clear the myeloma cells, it also clear normal plasma cells, so they're not making enough antibodies for a very long time. And this is a group that have already been through a lot of treatments. Infections in this group has high rate of serious complications. So we're now using a prevention of these infusion, this IVIG, a bit more proactively. And honestly, I'm not sure whether it is preventing infection, but it is definitely something that we can do. So we have been.
I think this is sort of something that nobody's really sure about. Most people will look at a total IgG level and say if it's below 400 has been the cutoff, then we're going to supplement you. But there are definitely programs that never do that at all for their CAR T patients. I have talked to several people about that, and I don't think we have enough data getting fed in to know whether that's a good thing or a bad thing. But it's very institution specific about where you go right now, I think.
I agree.
And really, when your doctor is talking to you about this IVIG, it is with the idea that we would do it after we get insurance authorization, because cost is still a major concern. It's not necessarily approved for what we call a primary prevention. By the package insert, the way it's really approved is pretty tight. It's for just a few different conditions, but it worked in children who were born with very limited ability to make antibodies from congenital immune problem, and it actually was very efficacious to get those children past the first few years of life without losing them to infection. So it's more of an indirect way that we adopt for our kind of problem, but it's not fully analyzed in myeloma. So we talk a lot about like survivor, right? We talk about like long-term bone problems, infection. Because in the morning we talked a lot about how to go after the cancer. We must kill cancer. So I am hoping to build on that, on sort of return to normal. What does that normal really look like? And one thing that I actually have caught myself maybe not doing a good job and trying to do better is to talk about cancer screening. It turned out that surviving one cancer is unfortunately a risk for being around and unfortunately facing other cancers in a lifetime. Some of the treatments that we were using, including this high-dose chemotherapy and stem cell transplant, some of the maintenance strategy that we do, this lenalidomide that we keep patients on for maintenance therapy, actually increase risk of second unrelated cancer. And I found myself not talking enough to my patients about cancer screening. Some of you have had me hounded you to say, go back to your primary care, please get pap smear, mammogram, and all that. But I wonder, when do you think that we should be returning back to those things? Like, and that's in addition to, talking about cholesterol, diabetes, and all that.
Yeah, I again must say that I probably don't do as good a job as I should be doing, but I think that it is something that should, until this patient is very sick, not be interrupted at all, and they should be continuing with this because the survival of patients with myeloma is now in transplant eligible patients going above 10 years. Probably is going to be much higher with all these new therapies soon, so those things remain very relevant.
Yeah, and I try to target my recommendations for cancer screening to what I think makes sense. So unless you have a very strong history of breast cancer in your family, really the target women should be for sure probably ages 60 to 70 actually is really where the peak incidence goes up, and you're really doing a good job in terms of cost effectiveness of mammograms. But some people, has anybody had their doctor say you're too old for a colonoscopy? I actually still send people for them now because of this concern that we're talking about. So I do that. Boy, do I get on people about smoking. And even though I know patients are cringing, I will bring it up every single visit if they're still smoking, because that's actually been shown to be one of the best ways to get people to quit smoking is just bring it up and bring it up. And every time, like, don't let it slip under the rug, just keep going. But I think we've all probably, I've had several patients die of lung cancer, unfortunately, although their myeloma's been doing great.
Yeah, I mean, I couldn't agree more. And, I talk about this epigenetics, right? So it's do what you can in your ways to help boosting your own long-term outcome, and additional exposure to what you don't need isn't helping, but also putting your body to be exposed to things it needs, adequate exercise, nutrition. It's a good thing to do anyway, even if one doesn't have cancer, but it may also have indirect effects on this reversible epigenetic changes I was talking about. But maybe I'll talk about the young patients too, because guess what? I've seen younger myeloma patients. It used to be that I was younger than them, and now some of them are younger than me. Do you bring up fertility and sort of having children in the future, and when to do that?
Yeah, fortunately, we've had very, very few women who are young who've been diagnosed with their myeloma. We've had one individual who was 8 months pregnant when she developed myeloma, and that was difficult, but she was able to deliver us successfully. And that doesn't come up very much. Often what happens, at least in my experience with younger women who've been diagnosed, they're in sort of a life-threatening situation where, for example, we had a very young woman present with just a profound kidney failure, like needing to go to dialysis right now. And it was clear that this individual needed to start on treatment. You can do, I don't know if this has come up, you can do egg harvesting, but it takes a little bit of time to get that set up. And in the patients who that would have been relevant in that I've seen, there just hasn't been a nice window to do that. They've just been too ill from their myeloma.